Welcome to this explainer. Today, we're tackling something that brings a lot of people a significant amount of stress: deciphering a skin biopsy report. You know the feeling. You get this piece of paper, or you open up your patient portal, and suddenly you're staring at a massive wall of complex medical jargon. It can be incredibly anxiety-inducing. But today, we're going to translate all those complicated terms into clear, actionable next steps entirely without the anxiety.
Just a quick note before we dive in. The evidence we're covering today is current as of July 11, 2026, and it's all been reviewed by Dr. Thomas Hocker of SkinTrust.com, who is a triple board certified dermatologist, Mohs surgeon, and dermatologist. All right, so let's get right to the elephant in the room. You've got this piece of paper, it's full of terminology that looks like you need a medical degree just to pronounce it, and you're wondering, what does this biopsy report actually mean for my health? Well, here's the direct answer. A biopsy report identifies exactly what's in that specific sample of tissue. Think of it as your very first treatment map. It points you and your doctor in the right direction. But, and this is a really critical distinction we're going to keep coming back to, it's not always a complete picture of the whole tumor. It's the starting line, not the final destination. Now, when you look at this document, don't just read it top to bottom like a novel. You actually need to read it in order of priority. First, look for the big headline, the diagnosis. This tells you what the lesion actually is. Are we talking about a cyst, a basal cell carcinoma, a melanoma? Once you nail down that headline, then you zoom in on the smaller words that follow it. Words like subtype, which tells you how it's growing, differentiation, which shows how abnormal the cells look, and depth, showing how far down it extends. Those smaller words are super powerful because they help answer the next big question: what does this diagnosis actually require us to do? I know, staring at these reports can sometimes feel like trying to decipher an ancient alien language. So let's translate a few key terms into plain English so you can actively chat with your doctor. Take histologic subtype. That simply means the microscopic growth pattern. Your follow-up question should be, is this a low-risk or high-risk pattern? Then there's differentiation. That's just a fancy way of asking how much these tumor cells still resemble normal cells. Ask your doctor, does this grade actually change my treatment? And perineural invasion. That means tumor cells are hanging out around or inside a nerve. We'll touch on this more in a minute, but if you see it, definitely ask, how extensive is it and should I be having symptoms? Let's pause for a second with a visual metaphor that brilliantly explains why a biopsy is just a sample. Imagine your skin lesion is a giant patchwork quilt. Taking a biopsy is literally like cutting out one single square from that quilt. Now, if that square happens to be blue, it tells you definitively that there is blue fabric in the quilt. But it absolutely cannot prove that every other square in the entire quilt is also blue. There could easily be red, yellow, or green squares hiding just outside the tiny spot they checked. And that brings us to the real-world limits of just taking a sample. Tumors can be heterogeneous, meaning they mix it up with different growth patterns. Basal cell carcinomas, or BCCs, are a perfect example of this. Studies actually show that an initially non-aggressive biopsy misses a more aggressive component hiding elsewhere in the tumor in up to 7 to 11% of cases. Because a partial biopsy can miss those aggressive parts, your treatment planning can never rely on just the biopsy alone. Your doctor has to look at the big picture, the actual clinical borders, the physical size of the lesion on your skin, all of it. Because a biopsy is just a sample, you might spot the phrase positive margin, transacted, or involved margin on your report. If you see that, take a deep breath, okay? It simply means that whatever they diagnosed reaches the very edge of the tiny sample they took. On a diagnostic biopsy, where the goal is just to identify the lesion, not to remove the whole thing, this is incredibly common. It definitely does not mean the biopsy failed or was done incorrectly. But that naturally leads us to a pretty massive question. If positive margins are common, what happens if your biopsy for something like a basal cell or squamous cell carcinoma actually comes back with a clear or negative margin? Does that prove the cancer is completely eradicated? The short answer is no. And this is a crucial point to understand. In a literature review of 221 diagnostic biopsies that were reported as having negative or clear margins, residual tumor was actually still found 24.9% of the time when they went back for definitive treatment. Almost a quarter of the time. Let that sink in. You simply cannot use a negative margin on a diagnostic skin biopsy to declare a skin cancer cured. The biopsy's job is just to establish the diagnosis, period. Okay, let's demystify another term that tends to cause a lot of unnecessary panic: perineural invasion, or PNI.
Yes, this means tumor cells are growing around or inside a nerve. But people hear nerve and instantly assume the cancer has spread all throughout their nervous system. That is not what that means. PNI can actually just be an incidental microscopic finding in a single tiny nerve. How significant it is depends entirely on how extensive it is and whether you're actually feeling symptoms. That is exactly why it's so vital to tell your doctor if you have any new pain, numbness, tingling, or weakness in that area. Now, if your report happens to be for melanoma, you'll notice it uses a totally unique staging language. You don't have to become an expert here, but knowing a couple of phrases helps. Breslow thickness is a big one. It's simply the measured depth of an invasive melanoma in millimeters. You might also spot ulceration. In this context, ulceration means a true tumor-related loss of the skin surface, not just a scrape from the biopsy itself. And mitotic rate just records how many tumor cells are actively dividing. These are highly specific terms, so you'll definitely want to chat through them directly with your treating team to understand your specific stage. Sometimes you're reading along and you hit words like atypical, cannot exclude, or additional studies pending. It is so easy to read that and assume the worst, like it's a secret code for disaster. It's really not. It's just uncertainty language. It's the pathologist's way of saying, hey, based on this tiny sample, I can't put this in a fully secure category quite yet. And honestly, that's a great thing to see because it gives you the perfect, empowering question to ask your doctor. What info is still missing here and how do we get it? And that highlights a really fundamental truth about all of this. A pathology report is literally just a microscope document. It completely lacks clinical context. It doesn't know how big the spot is on your arm, it doesn't know if you're having symptoms, and it doesn't know your immune status. This is exactly why you should never copy-paste a single line from your report into a search engine to try and figure out your treatment plan. The report gives you the biology, but your dermatologist provides the context. They're two totally different lenses focused on the same problem. Because context is everything, a scary-sounding report doesn't always automatically mean you're rushing into surgery. For example, researchers looked at 467 moderately dysplastic nevi, basically atypical moles. These had positive histologic margins on the biopsy, but there was no visible pigment left on the patient's skin. Out of all 467 cases, not a single one turned into melanoma at the biopsy site. So in that specific context, the right next step was just whole skin surveillance, not doing more surgery. The lesion, the body site, and the patient always have to be considered together. So how do we put all this into action? Here is a quick, exact checklist of what you need to bring to your next treatment visit to really empower yourself. Step 1. Bring the complete pathology report, the whole thing, including all addenda and comments. Step 2. Make sure you know the exact date of the biopsy and the exact spot on your body. Step 3. If you snapped a photo of the spot before it was biopsied, bring that too. Step 4. Have your current medication list and any history of immune suppression ready. And step 5, write down your specific questions for the doctor beforehand. Please, don't rely on your memory in the heat of the moment. Ultimately, the goal here is clarity, so you can feel empowered about your health. As noted in the source material, Dr. Hocker actually created Skin Trust with that exact mission, to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. So I'll leave you with one final thought. Next time you sit down with your doctor, report in hand, I want you to try asking them this exact question. Which exact words on this page actually change what happens next? Use this report as your map. Ask great questions and really take ownership of your treatment journey. Just remember, this explainer is meant for general education, not individual medical advice. Thanks so much for joining me today.